Hello, everyone, and welcome to the fourth session of the Building Your Defense Expert Speaker Series brought to you by Brownlee LLP in partnership with Viewpoint Medical, Invista Forensics, and Westbridge Ventures. My name is Nabil Pir Mohammed. I'm a partner with our Insurance Defense Group, and with me is my associate, Kara Shaw. We are your hosts for this six-part speaker series.
The series is focused on emphasizing the approach to defending personal injury claims by not just arguing the holes in the plaintiff's case, but rather building a defense by hiring the right experts to build your defense. This is the fourth of 6 sessions where we have invited leading experts in their respective fields, featuring the experts that testified in our recent trial victory, Armbruster and Netting, where the plaintiff effectively recovered nothing from a $2 million motor vehicle lawsuit. After we hear from our expert, we will address questions you type into the chat. And then after today's session, we will also email you asking for your CIP number to issue your credit certificate.
Today is our fourth session, and we are pleased to be joined by Dr. Mundin, who was our expert rebuttal psychiatrist who testified in the Armbruster trial last year, which contributed to our success. Since 2003, Dr. Mundin has provided comprehensive assessments and treatments for patients with severe mental illness across various settings, such as hospitals, offices, jails, workplaces, and for medical legal purposes. Dr. Mundin has a special interest in schizophrenia and psychotic disorders, postpartum, menstrual, and menopausal mental disorders, non-stimulant treatment for ADHD, disability, and fitness for work. She is certified as an expert witness in psychiatry in Alberta, British Columbia, Texas, and California. Dr. Mundin, thank you very much for joining us today.
Thank you for having me. It's great to be here.
Dr. Mundin, can you start by telling us a little bit about your professional background and what led you to psychiatry?
Yes. I'll start by saying it's weird for a psychiatrist to talk about herself. I think it's taught into us that we shouldn't reveal much about ourselves when we're meeting with patients. So to have to actually talk about myself is just feels funny. So I'll start with that. I was born and raised in Regina, Saskatchewan, so a small farming community. And as a kid, I remember really never enjoying reading fiction stories. I loved reading biographies and true stories about true people. And when we finally got cable TV and the biography channel came on, that was my jam. That was fantastic. And so looking back now, I recognize that that was the beginning of my interest in people and their stories. And I never thought I would go into medicine. In a million years, I had no role models in that area, except that when I was doing my chemistry degree at the University of Regina, a lot of my peers at the time were applying to medical school. And so I thought, well, I'll try that and see what happens. And I got in. So I got in as a very blank slate, again, because I had no sort of preconceived role models in medicine. And because of that, I think I was able to really just experience everything it had to offer me. And it wasn't until I did my psychiatry rotation, almost at the end of my training, that I found my niche and realized that's where I wanted to be. And so I happily went off and did my psychiatry residency at the University of Saskatchewan in Saskatoon. And that's where I learned how to diagnose and treat mental illness. Once I completed my residency, I went off to the University of Calgary. And that was at a time when it was a wild west, in a good way, for young psychiatrists, young doctors, because there was such a need for services and there just weren't bodies to fill those services. So young people at my level of career had opportunities that you wouldn't get today, to be on committees and head projects and do all sorts of things. And so I wound up in the medical school in Calgary. And it was during my years in the Calgary Medical School that I taught across all levels of training, taught medical students, residents, nurses, social workers, and really cut my teeth and learned how to be a teacher. And that has served me well now when I'm in court, because I see court and writing reports as well as teaching what I think is happening with this person. So after about 10 years doing that, I moved into private practice where I really focused on the medical legal side of my work, became crazy busy with that. And I don't know where we got the idea, but one day my husband said we should try and move to the States and see what happens down there. And so gradually we worked through the process, the very long process of getting a green card, getting certified for my American board examinations. And I was recruited by the state of Nevada, to work for their healthcare system, which is very much like Canadian healthcare, caring for really mentally ill people who don't have private insurance. After working with them for a couple of years, I was recruited by the Clark County Detention Center, which is the great big jail in downtown Las Vegas. And I worked there for several years doing jail psychiatry. And that was it. I really was bit by the bug at that point. And so since 2019, I have been in jail psychiatry in one form or another. And currently I work in both Texas and California through telehealth into a couple of jails and prisons.
Oh, wow. That's really interesting. Quite a broad array of areas in a way to jump from one to the next.
It's been a crazy life. Never thought I'd be here.
Going back to, I guess, a bit of the teaching part, I'm hoping you can give us an overview of what psychiatry entails and what the scope of practice for psychiatrists is.
So psychiatry is the medical study of how and why people think and feel and behave the way that they do. And that sounds like it has a lot of crossover with neurology, psychology. Here in the US, even internal medicine does a lot of psychiatry. And so the question on scope of practice is a good one. And I like to compare the various specialty scopes of practice with a computer. So if you can see my desk right now, I've got 3 computer screens and wires everywhere. And so I compare that to the brain and the nervous system. So the brain is that main computer, and then the wires are all coming out. And so I think neurologists, they are the experts in the brain as a hardwired system, or the hardware. So they're the ones who know how to look for brain tumors and skull fractures and brain bleeds and just that damage to the structure of the brain. I think that the scope of practice for psychiatry is to look at the software of the system. So we're looking at how the brain is functioning and how that translates into the way this person, thinks, feels, and behaves. And then I really value input from psychologists and their expertise in debugging systems. So they're the ones I think who can, look at a computer system or a brain system that's not working properly and say, well, I think that wire is loose, or I think that screen is cracked. They might not be able to comment on the reason behind those cracks or the broken wire, but they can really hone in and say, that's not working. And then together, all the specialties can come together and opine on the reason.
Perfect. I think that segues really nicely into then talking about what exactly would a psychiatric evaluation look like, and what would be the primary purposes in the context of insurance and litigation in general.
So I think it's important to start by pointing out that a psychiatric evaluation should be done by a psychiatrist. I'm seeing more and more evaluations that are labeled psychiatric evaluations, but they're not done by somebody who's trained in psychiatry. So I think that's important to recognize that the evaluation I do as a psychiatrist is not the same as what a social worker might do, or a nurse practitioner or a neurologist. So just recognizing who is doing that evaluation is the first step in concluding that it is a psychiatric evaluation. And it's fairly simple. It consists of two steps. The first step is hearing from this person, listening to them, not talking to them, because I shouldn't do much talking, but the first step of the process is hearing their story as it comes to me. And then the second step is collecting as much collateral, external, other information I can about this person, whether that's from insurance files, school records, other medical records. All of that collateral information is probably more important than what I hear from the person, him or herself. And the purpose of considering all of this data is to create what we call a biopsychosocial understanding of this person. So I want to understand why this person is mentally functioning the way that they are because of their biology, because of their psychology, and because of their circumstances.
So then, and of course, without getting into specifics about various patients and plaintiffs that we've seen you provide opinions on, and I think you've already delved into this with your previous answer. The next question would be, can you describe the process of conducting a psychiatric evaluation and what specific factors are considered? I think the audience would be very interested in hearing your perspective on what those factors are, and maybe what are you looking for in terms of doing your own sort of credibility assessment? Because as we all know, I think credibility is a big deal, and our audience can be a little skeptical of what plaintiffs are saying.
Yeah. So the first step of the assessment comes in the form of the referral letter. And so what's really valuable from my perspective is just simple questions. What do you want to know about this person that I can help you with? It's not usually helpful for the referring agency to spend a ton of time writing a background summary of this person, because I'm going to go to the horse's mouth. I'm going to look at the actual records where you probably got that information. So spending that time isn't valuable for you. They're really telling me, like, what are you concerned about? What do you need to know? What can I help with? That's the important first step. Then the next step is sitting down, either through a screen or across a table with this person, and just being prepared to hear the person tell the story from their perspective in whatever way they need to tell it. And I emphasize that because I think sometimes people try to have very rigid approaches to the psychiatric evaluation. And we're going to talk about this, and then we'll talk about that. And next, it's going to be this topic. But that's not how people experience their lives or tell their stories. And so the evaluation is very much a matter of just sitting and listening and hearing what this person has to say, how they're going to say it. Once the person has told their story, then there are some important other areas to touch upon with some specific questioning. For example, does this person have a family history that runs in the family? Does this person have an intoxicant use history that's relevant to their mental functioning? What's this person's employment or academic history? These are all important details that people might not recognize as necessary in, for example, a car crash case. But from a psychiatric perspective, this person's experiences from birth to the day that we meet them, all of that's valuable information that we need to consider. And then I think, does that cover your question? I think it does.
Well, yes, and then, what we'd be interested too is understanding, you mentioned that you look at the collateral information, and that appears to be more important to you than the interview that you have with the plaintiff. And so from your perspective, the collateral, you're saying the collateral information is more important, and then maybe you can elaborate. Why is the collateral information, the medical records, the narratives, the pre-existing history, the symptomology, all of that, why is that more important than your interview, either through a screen or in person, of a plaintiff who's alleging psychiatric injuries from perhaps a motor vehicle accident or a slip and fall?
So I think this goes back to my love of helping people with schizophrenia and psychosis. So schizophrenia is a condition, it's a mental disorder that causes a person to not know what's real and what's not real. So these person might think they're aliens talking to them, or the internet's following them. And so typically these people will come to me and say, no, I'm perfectly fine. They might appear fine. They say, no, I've got no problems. I'm all good. And then I find out from family that no, this person's actually been starting fires in their electrical sockets because they think that there's sound coming out of it. And then I look into their records and find out, oh, this person was academically gifted until grade 9 and then failed out of high school because the start of mental illness took away their academic abilities. So that's a really common example of how I can never accept what the person in front of me is saying, because their experience and their report of their circumstances is not necessarily what other people say to be true. So I need to consider all of that. In medical legal settings, I get maybe an hour or two with this person. I get a snapshot of this person, but we're talking about difficulties that have been years in the making. And I need to know how this person was before and since whatever that event was. And so that requires collateral information. This person often won't have the information that I need from medical records or the radiologist report or the employer's observation of their functioning after an accident. All of that has to be considered to get a full understanding of this person's condition.
Perfect. So before I ask my next question, I do want to remind the audience that we are taking questions in the chat and through the Q&A tab at the bottom of your screen. So please feel free to type in any questions that we will have Dr. Mundin address at the end of this session. My next question, Dr. Mundin, then is, in what scenarios are psychiatric evaluations typically requested? Specifically in the insurance world. So are you seeing them from more of a defense perspective, from more of a plaintiff perspective? And, you know, without getting to specifics, we had experience with you giving us a psychiatric opinion of the plaintiff in the armbruster and nutting trial. And what was interesting in that one was you did conduct a Zoom interview of the plaintiff, and you actually appeared in trial over remote. And if we read the decision, it's a good read for all of us to go into that decision. Your opinion actually was highly accepted by Justice Wilson. And so, you know, I don't think we necessarily need to be apprehensive about your assessments being done remotely. So maybe in what scenarios are your evaluations typically requested? What are your typical requests?
So I think anytime anyone has a concern about how somebody is thinking, how they're feeling, what their emotions are like, or what their behaviors seem to be, those can be reasons for referral to a psychiatrist. In the context of the medical legal setting, very typically, and I'm happy about this, I receive the referrals towards the end of the process. So by the time I'm asked to see this person, the neurologist has talked about, you know, the hardware. Is there a brain tumor? Was there bleeding in the brain? Was the skull fractured? The psychologist has done his or her, you know, debugging and glitching and looking to see how this person's brain is functioning. And so then I get the benefit of all of that information by the time that I'm thinking about this person. So in terms of timing for a psychiatric assessment, from my perspective, the later in the process, the better, because the more information, the better. And in terms of the comment about telehealth, COVID really taught us, I mean, there are bad things, obviously, that came out of COVID, but COVID definitely taught us that we can do telehealth psychiatric appointments, not just non-treating medical legal examinations, but also as a treating physician. We can do them successfully and often even more comfortably for patients or examinees than in a face-to-face setting. So
that makes a lot of sense. And I know you've mentioned kind of a holistic approach that you kind of like to look at everything. Are there certain things you're looking for when you're performing a psychiatric evaluation, when it's medical review or in person, over telehealth, kind of virtual conferences?
Yeah, I am constantly looking for both subjective and objective information. So the subjective information is what this person is telling me at the time that I see them. That's all important information. But at the same time, I'm trying to take in the objective observations that I'm making. And so, for example, in the jail setting where I do a lot of work, a lot of our inmates want sleeping pills. And so they will say, oh, I can't sleep. But they're, you know, they've got good color in their face, no bags under their eyes. Before I got there, they were actively playing basketball in the rec yard, no signs of insomnia or fatigue. And so that's an example of a person saying to me, I can't sleep, and yet I don't see signs of insomnia or fatigue. It's important to, I think, always be looking for that information. It's not to say that a person is faking. As a psychiatrist, I can't really even examine faking or malingering. But what I can tell you is there's a mismatch between what she's telling me and what I'm seeing. And then together, we all have to figure out why there's a mismatch.
Makes sense. Are there any insights you could provide the audience about certain psychiatric tests?
So I think the tests that psychiatrists can run refers to things like the PHQ-9 or the GAD-7. These are tests you've probably seen referenced in different reports. And the criticism I have of those tools is that if they rely strictly on the person's report of his or her experiences, then they're not that helpful. They're actually not helpful in the medical legal setting. The testing that I think is the most powerful is what a neuropsychologist can do. So the neuropsychologist can do IQ testing. They can test, whether the front part of the brain is working, is the side part of the brain working. And the results of those tests typically are not influenced by how the person wants to present him or herself or how the person feels about their circumstances. So these are objective test results, very different from if I ask somebody, is your mood bad? Well, yeah, my mood is terrible. Are you anxious? I'm so anxious. Well, that's not helpful information. And so much of the psychiatric testing that you hear about is that kind of data collection, not helpful.
Right. That makes total sense. I've definitely seen a few of those.
So just to jump in real quick then, Dr. Mundin, is your recommendation that a neuropsych evaluation take place first with the testing before you get a referral? Is that something you'd like to see first?
That's my preference because, like I said, that data is so powerful, whether it's, showing abnormalities or normal functioning. It's really powerful data. It's typically very objective. And so I can depend on it when I then meet this person and hear what their experience is like.
My next question is, I guess, about different diagnoses. So I'm hoping you can kind of tell the audience about diagnoses like chronic pain syndrome or somatic symptom disorder, and the recommended treatment, the likelihood of recovery.
So somatic symptom and related disorders, that's a whole section in the psychiatry textbook. And it's meant to recognize and capture the fact that there's a mind-body connection. So if, for example, my mind is worried about something, I can feel it in my body in the form of butterflies in my stomach. There's a connection. And in other instances, the connection can be extreme and severe to the point that it should be labeled with a diagnosis, like somatic symptom disorder, for example. These are not new conditions in medicine. All the way back to Hippocrates, he was describing what he thought was a mind-body connection, in that somebody who has depression, for example, had black bile in their body. So he wasn't quite right about it, but it was a recognition that the mind and the body are connected, and we can never ignore that. The challenge with something like somatic symptom disorder, I'm seeing it a lot in medical legal files, and the issue is that, in my opinion, it's being overdiagnosed and misdiagnosed when the examiner considers only the diagnostic criteria in the textbooks without understanding and fleshing out what those criteria mean. So to explain that, what I'll say is that, imagine you want to bake a cookie. You have to go get the ingredients to make your cookie. So you'll have flour and sugar and oil and eggs. But if all you have is flour and sugar and oil and eggs on your table, that's not a cookie yet. They have to come together. They have to cook for a certain time. The right proportions of ingredients have to be mixed up for you to make a cookie. So when we look at our psychiatry textbook, which lists the diagnostic criteria for conditions like somatic symptom disorder, the very first part of each chapter gives you the ingredients, like a cookbook. So if these ingredients are present, then the person could have somatic symptom disorder. But where people often stop is at that list, and they don't get into the remainder of the explanation in those chapters, which is how these ingredients have to combine, for how long, at what temperature, on what cooking pan to make a cookie. Or is this a cake? Or is this a cinnamon bun? We have to really get down to that. And I think that's one of the challenges I've encountered in medical legal files, is recognizing when a diagnosis has been established because there are ingredients on the table rather than actually a baked cookie at the end of this process.
Amazing. I really like your analogies. They're great.
Good teaching.
So I think one of the things, that we've seen with, I think you experienced this as well. Previous experts have said that there's this thing about hurt versus harm counseling. And the idea is to nip the symptom in the bud, so to speak, whether it's chronic pain syndrome or somatic symptom disorder. There's the interplay between what you're physically experiencing and then the brain getting, I guess, used to having that pain, and then leading into symptom entrenchment when you don't have the hurt versus harm counseling or the treatment. Can you comment on that? Because one of the things that we always see is this, maybe the overdiagnosis of chronic pain syndrome or somatic symptom disorder, and it just happens to be too late. And at that point, when you see the file, we're 7 years, 10 years post-accident, and then there has been this symptom entrenchment. So when you're seeing these, the overdiagnosis of these conditions, is there something like hurt versus harm counseling or just general psychiatric or psychological counseling you'd like to see early on with the patient?
Yeah, so one of the things I didn't mention in my opening statements is that I did a 2-year fellowship in early intervention in psychosis, so in mental illness. And the philosophy there was very much, if you catch someone before they fall, catch them before they decline into the signs and symptoms of severe mental illness, they have better outcomes. And so that's carried with me into this work as well. I think the earlier, the better in terms of health interventions. The issue is that I was taught by a really wise psychiatrist once that when all you have is a hammer, everything looks like a nail. So as psychiatrists, we're trained to diagnose illness and treat it. Same thing with psychologists, neurologists, all of us. And our healthcare system really isn't geared towards health identification. It's towards disability and disease identification. And so we're part of the problem, I think, in supporting that sick role, where people just become so entrenched and identified with their illness that it's in itself becomes the disability. And of course, when you layer on the specter of, maybe a compensation at the end of a process, that's just another influence to consider that could force this person deeper into their sick role. So I agree, the sooner that, a symptom can be addressed aggressively, the better. And there are various types of counseling and therapies that can be used in that vein. I think it's up and coming. I think the really good therapists, like the dialectic behavior therapy therapists, they're the ones we should be using, but their training is extensive and it's still up and coming. So my recommendation is a really good DBT therapist if you want to early intervene with somebody who's got symptoms following a collision.
And then, of course, when you review the medicals, when you review the collateral information that you talk about, if you have seen those recommendations being made to a patient and then you see no follow through, at that point, are you able to not necessarily call the plaintiff a malingerer, but are you able to then make comment that there has been sort of a resistance to recommended treatment and there has been a failure to follow through with recommended treatment, and then it has had an effect on the plaintiff and your evaluation of that plaintiff?
Sure. I mean, it is what it is. If factually that's the case, that this person, either wasn't offered a certain intervention or was and declined to accept it, that just is what it is. But then that fact has to be incorporated into my understanding of this person. And in that case, yes, I would comment that the absence of early intervention reduces good outcomes. And that could be what happened in this case.
Then my next question, or our next question, is what specific information or evidence are essential for you to provide an accurate and reliable evaluation?
There are probably three categories of information, the two being the most important. Collateral information is everything. I just need to know school records. I need to hear about employers' observations. I need to hear what family thinks about this person. That's so important. As well, observational data is so important. Again, that inmate who is happily playing basketball in the yard and then comes to me hunched over and says he's so tired. That observation, it was really important to my conclusion for this person. And then I think, third, I have to hear from the person and hear his or her description of what his life or her life feels like. But in the big scheme and the weight of things, the first two data points are very powerful, very powerful.
So then that leads into a bit of a segue then. Without getting into specifics about the Armbruster and Nutting trial, we know social media was a big part of that trial, was a big part of the evidence. So you don't get the benefit, I think, of observing a plaintiff like you did with the basketball. Typically, with a motor vehicle, you basically get to interview this person either in person over Zoom. You get the collateral information, and maybe you have the benefit of previous expert opinions on one side or the other. But then in that case, with with the Armbruster trial, you had the benefit of a lot of social media material, almost 10 or 12 hours of video footage, self-authored by the plaintiff. And you had LinkedIn posts, Facebook, Instagram, YouTube. You had all of that with you. So then how important then is that collateral information to your psychiatric evaluation and your opinion overall when you draft up a report to be presented in trial?
That data is so important. Again, because I have a small snapshot of this person during those minutes that I talked to him, but getting a timeline, a visual and audio of this person's functioning, how this person thinks, how this person feels about certain situations, how they act, for example, in videos on social media, that's just a goldmine of information. There is debate in the academic literature about whether it's ethical for psychiatrists to just go and get that information on her own. But in this setting, that's different. It was provided. It was part of evidence. And so it's reasonable here, I think.
Right. I think the main point, though, is you would like to get your hands on all information that can be ethically obtained so that you can provide a well-informed opinion and report.
Yes. I laugh when I see health records, not the social media records, but health records that have been provided, but someone has gone through and redacted parts of the data with, thick black marker. I don't know who does that, but it always makes me chuckle because I can't think of much in psychiatry that is not important for me to consider. And so I don't know, when redacted data, I don't know what thought process goes into holding that back, but social media is how this person is presenting him or herself to the world. And I think that's really important information to consider when thinking about their mental function.
So then two things then come out of that in terms of your recommendation. One would be you're ethically bound. You can't go out and look up someone. You can't Google them. You can't look up their social media, but we can through open source investigations. So you'd like to see that, and we can get that through our sources. And then the second thing is you would like to get even unredacted copies of all medical records. And so when you see redacted copies, are you vocal in telling us, hey, listen, you've given me a bunch of redacted medical documents. I would like to see what's behind those redactions. Are you then vocal and telling us, I need to see those?
I will absolutely speak up and point that out. What I've typically recognized, though, is that there's so much data in the records that even if something's been redacted, the picture is pretty clear. And so the absence of that piece of information is probably not critical because the story is telling itself in the records. But if I do think that there's something hidden by that black marker that I can't find anywhere else, I will absolutely speak up and point that out.
Right. And then, during the trial, I think there was some discussion about whether you had read everything beforehand. And I think you had adopted a methodology that you wanted to hear from the plaintiff first, and then you were going to go and re-review medical records or the file the brief that we gave you. And so is there a difference? Is there a cart before the horse scenario here, or does it really matter? You have to do the interview, you have to review the records. Does it matter in which way you perform those two tasks? And is there an impact on whether it influences what the report or the opinion is going to look like?
I do think it matters that I know very little about the person before I meet him or her. I think it's only fair to hear their story from them first. And they want to be heard. And that's partly what my job is in that moment, is to hear them. I think as well that my experience in the jails has influenced my philosophy, because in the jail setting, as a treating psychiatrist, I really shouldn't know what the person is charged with, because some of the charges are awful. And the risk is that could influence my decision-making to take care of my patient. And I can't let that happen. So I need to get to know my patient first, or my examinee first, before I hear what other people think about this person. And I think it's just the best practice.
So you've made an active decision then to not look at the collateral information first in your methodology specifically with these medical legal psychiatric evaluations. You've made a conscious decision to review records, review the brief, review all the medicals after you've conducted your interview and your in-person or Zoom psychiatric evaluation.
Yes. Yeah, that's right. The only thing I look at in terms of records before the actual meeting with the examinee is the list of questions, just in case there's something unexpected in the questions. You know, if they ask me to examine for a really rare psychiatric syndrome that's just not a typical part of an examination, I don't want to miss that opportunity. So I'll look at the questions, but no other information, no summaries, no records, nothing like that.
Kind of like a don't judge a book by its cover, that sort of saying.
Exactly. Yeah, exactly. Yeah.
The two of you are getting along with your
my people.
Yes, I like it.
Very nice. So then you typically get almost like a common list of questions, not delving into any specific cases that you've seen, but in general, you get a lot of instruction letters. You get a lot of questions. And typically, you probably see the same questions coming up more often than not. Are there any questions that you find are good, that are helpful, that direct your analysis? And are there any questions on the opposite end that detract from your evaluation, or that you commonly provide answers saying, I am not qualified to answer this question? Are there basically questions to ask you and questions to avoid when we send you a referral?
I wish more referral letters asked me to create a differential diagnosis.
You're a dog owner too.
Yeah.
Yeah.
I get it. Protective, it's nice.
Yeah. I'm assuming that was a dog.
I've got 2 German Shepherds and a little white terror, little white poodly thing.
Oh,
and
yeah.
just walked by my window. They're going bananas now. Okay.
Oh, interesting.
I'm so sorry.
All good.
I wish I would be asked more to give a differential diagnosis. I wish all the experts were asked that question. So differential diagnosis is a skill that every physician has. We're taught how to do this from day 2 of medical school. And it's just a list of the top 3 or 4 most likely explanations for this person's presentation. So for example, if someone presented a couple years ago with a runny nose, we were saying, well, COVID's at the top of that differential diagnosis, but it could be allergies. It could be just a common head cold. It could be an ear infection. And as an expert, I need to be able to defend what's at the top of my differential diagnosis, but also logically help my audience understand why I've ruled out the other reasonable explanations too. I don't see enough of that in reports, and I wish it was there, because I think it would really hold us as experts hold our feet to the fire and just provide a valuable, more helpful service to all parties involved.
Okay, well, that helps. I guess the other question then is, specific to social media. I think you found the basketball activity helpful. And that was something that you gained through observation. Are there specific activities that jump out in your mind that contradict what a patient or a plaintiff is telling you in a psychiatric evaluation that you've then seen in social media more often than not, that makes you question what they're saying or makes you doubt that they really don't need the treatment they're asking for? Like, they don't need the sleeping pills because they're playing basketball. You saw them playing basketball just contemporaneously with the psychiatric evaluation, such that it makes you doubt there's no sign of insomnia or fatigue, so they don't need the sleeping pills. Is there anything in social media, like seeing somebody hiking regularly, skiing, water skiing, or perhaps there's a lot of continuity on a LinkedIn profile in terms of employment? What things sort of jump out at you specific to the social media you get and review?
So I guess yes to all the examples you provided. What I'm always trying to do is look for patterns and deviations in this person's trajectory in how they're thinking, how they're feeling, and how they're acting or behaving. And so videos on social media, especially where the person is talking or moderating or narrating an experience, that's really helpful because I can hear how that person's speaking. I can observe how they're putting thoughts together. I can observe if they're making a point, if that's the point of the video. That is data I couldn't get from a face-to-face evaluation of a person. I can also hear about what they're passionate about, what activities they enjoy doing, and see real-time examples of those. And that's really helpful, especially when I, meet examinees who say that they're so terribly unwell from a collision, for example. But then I see that on social media, they're scuba diving. That's just, again, a mismatch between what they say and what I see. And that mismatch has to be explained by somebody or decided on by a judge.
Okay. And then we've already talked about this too, in terms of gathering the information. So you typically get the collateral information from the lawyers. They give you the medical brief, the index. You then get information from an interview. You're ethically prohibited from going out and getting things from the internet, from getting social media. So you have to get that from us. Is there anything that jumps out at you that you like to see in the collateral information? And is there anything that you've noticed there's almost a pervasive gap in the medical briefs that you typically review that you would like to see and that you're vocal about then requesting?
I think where I tend to see gaps would be in the pre-event records. So if it's a collision, the pre-collision records. The refrain I'm often given is, well, that's before the accident. That's not relevant to the accident. But from a psychiatric perspective, a person's developmental experiences, their academic experiences, which usually happen before a car collision, those are so important in helping me understand why this person's presenting today with these problems. So that's the biggest gap I can think of is pre-event medical records. Right from birth, sometimes that's possible, but it can be really interesting to get these tidbits of information that just pull a richer picture together of this person.
And to kind of wrap up, I guess, what advice would you give to insurance and litigation professionals to help them better engage with you to defend personal injury claims from a psychiatric perspective?
I think I've already mentioned the value of inviting me or your experts to give a differential diagnosis, because that really forces a thought process and a consideration of all the data that I think can help you or an insurance adjuster to really understand what's going on here and then make good decisions. I would also suggest that file reviews should be used more. I know the reason for reluctance with file reviews. I know the perception is it's better to see a person than just draw conclusions from a file. But a lot of information can be drawn from a file review. And, sometimes that can help reduce costs or reduce time required to support or to do these examinations. So file reviews and ask for differential diagnosis.
Amazing. Yeah, that's a good one. I'm definitely going to note that one, the differential diagnosis down.
Yeah, that'll be
That's a really
our next
helpful one.
question.
Yeah.
So you're saying that you can actually do a psychiatric evaluation by a file review, by a document review only, without even having a in-person or over Zoom interview with the plaintiff?
Yeah, so in fact, just this week, I had another example of exactly what we're talking about. It's a case in California, and the patient is extremely unwell, and we need to do an evaluation to get this person forced to treatment, and she refuses to see us. And so I had to ask the lawyer, what do I do? How do I go to a judge and say I've examined this person and she needs treatment? And the interpretation of the relevant statute was that an examination includes looking at the files. And if a face-to-face is not possible, then the file review is sufficient. If I feel I can testify based on a file review, which I did in this case, then that's acceptable to that jurisdiction and that judge.
And specific to that case, the plaintiff, the patient, refused to see you. So you had no choice but to do a document review only and rely on that for your diagnoses and opinions.
Correct. And, as I said earlier in our conversation, because by the time I'm coming in, so much has already happened for this person. There's so many assessments on file. This person's told their story a million times, and telling it one more time to me doesn't usually sound any different to what I see in the records.
Okay, that sounds good. So I'm looking at the chat. I don't see anyone really asking any questions. Just a reminder, Dr. Mundin is with us for another 11 minutes. So if anyone has any questions, by all means, feel free to type it in the chat. This session is being recorded. So a video recording of this session will be released shortly on, ironically, social media. So it will be available, but I'm not seeing any questions here. But Dr. Mundin, before we let you go, is there anything that comes up in your mind that is outside of the questions that we've asked? Anything about the subject matter that jumps out at you that you feel that you could share with the audience? Your experiences, 20 plus years of experience in this field. Is there any insight you could share with the audience that we haven't discussed already?
I think that what I'm noticing being lost in the practice of psychiatry is the power of our observation. That really is our superpower. It's supposed to be anyway, that we just stay quiet, we listen, and we watch and observe. And so often now I'm seeing that a person's presentation of their story is accepted as hard, cold facts. And I go back to all of my psychotic patients who were convinced that aliens were here and were talking to them through their teeth fillings, and that probably wasn't true. And so just that value of looking at somebody and considering all this information, as we've talked about earlier today, I think that's a real lost art that we need to bring back. As well, I would say that this is a high stress area of practice. It's adversarial, and just the chance to work with legal teams that really just want to hear what you think and don't, direct you in one direction or another. That's really important. And I've done, cases for both plaintiff and defense. Probably at this point, it's 60-40, 70-30 maybe for defense. And I've encountered a lot of legal teams, and the ones who are just willing to accept it is what it is, they're the ones I like working with, because it's too stressful with everything else to consider. And so an understanding legal team is really valuable.
Oh, so when when the legal team is almost pushing back on your opinion, that's increasing the adversarial nature of the work?
Yes, pushing back and just, some of the experts can get into, tit for tat sort of arguing, either in rebuttals or in court. And that's just unnecessary. We should all be looking for the same end result here, which is a comprehensive, reasonable explanation of this person's condition. And, legal teams who understand that's all I can do. I like working with those teams.
Well, it's interesting you bring that up because that is what we experienced in the armbruster and nutting trial. But you rose above it and your opinion carried the day. The defense experts really did have a lot of weight placed on their opinions when Justice Wilson reached his conclusion. So I think that's valuable insight for all of us to take into account. We don't have questions per se, but we are getting a lot of positive feedback. Several people have said that this session has been very insightful, and they appreciate the insight and the sharing of perspective. We are getting a lot of those comments. So, Dr. Mundin, thank you so much for joining us today. We really appreciate your time, and appreciate all the insight that you've provided us. Last and final question, I think, unless you have one as well. What's your dog's name?
Okay, so I've got Bosco and I've got Scooby, and then I have Pickles.
Pickles. What a great name.
Oh, that's
Yeah.
great.
Yeah.
Well, thanks again. Thank you so much for your time, and thank you for being with us today. Audience, our next session is on November 13th with Robert Townsley, accident reconstructionist with Invista, focusing on the strategies and tools for determining how exactly the accident occurred. So again, thank you so much, Dr. Mundin. Thank you everyone for joining us today. Really helpful, really insightful, a lot of lessons learned, even from our perspective. Really appreciate you joining us over your lunch hour. And with that, we'll close the session. Thank you so much.
You're welcome. Have a good day.
You too. Bye.